This is your fortnightly instalment where I interview a trailblazing physiotherapist that has shaped the profession we are today. In celebrating their journey, knowledge and insights, you gain the opportunity to plan and guide your own professional journey. My name is Doug Carey and welcome to Physio+10. Welcome back, past listeners to Physio+10 and you people tuning in for the first time. Thanks for joining us. Our special guest today on the podcast is Diane Lee. Can you give us a bit of a background into your schooling and where you come from?
Yeah, I was born in Vancouver, but at a very young age of 10, we moved to a small town 3 hours east of here, which is Kamloops, BC. And it was there that I got involved in gymnastics. And it was there that I experienced my first body injuries. I had a very bad sprained ankle. I dislocated my elbow, did a back handspring on a balance beam and landed straddle. And that began my pelvic floor issues. So by the tender age of 16, 17, I had poor ankle control, a funky elbow, wrecked neck, and was incontinent. And I had no treatment for it other than some ultrasound on my elbow. The experience with the physiotherapist then and the whole environment of helping people kind of piqued my interest when after I graduated, I really wanted a gap year to go to Europe, but my father insisted that I had to go to university, and I absolutely did not want to be a school teacher. I hadn't a clue what I wanted to do. So I applied for one of the most difficult programs to get into at the time. There was 800 applicants and only 30 people got in. And gall darn it, if I didn't get in and I had to go, otherwise I'd admit I had lied to my father. So I ended up in physiotherapy, not knowing what the heck I was getting into, because I didn't really want to go. I didn't want to go to university that year. So that was my start of the whole thing. And while I loved the academics of the program, particularly the neuroanatomy and the neuroscience, there wasn't very much in 1972 to 1976, which is where my bachelor's degree was at the university, where there was any clinical application of the fascinating anatomy and neuroscience that we learned. So clinical practice of physiotherapy in the 70s was all, fitting crutches and teaching people how, to walk and range of motion exercises. And while that is very necessary, it really didn't challenge my brain the way that the academics did. So all of my learning in terms of orthopedics and manual therapy and everything was all postgraduate. There was nothing in school at that time. So and I also, while I really loved the neurosciences, there was really not much that we were doing at the time with people who had suffered catastrophic neurological injuries, whether it was a stroke or quadriplegic, like there is now, to really get me excited about going into it. And I had 9 months of hospital experience. And at the end of it, it was like, get me out of here. I don't want to deal with the risk of someone dying. I really want to improve quality of life. So there were very few private practices in Vancouver at the time. In fact, there was only 3. And I felt at that time overwhelmed, undereducated, useless. I didn't think that anything I did made any difference to anybody's outcome. And, by 3 or 4 years into practice, I was ready to quit. And it was right about that time, my husband, who was a pharmacist, he hated pharmacy and he wanted something more mentally challenging as well. And he got accepted into dental school. So somebody had to pay the bills and feed us. And it was right at that time that I was introduced to Cliff Fowler. And Cliff Fowler is like Australia's Jeff Maitland or Robert Elvey, as you mentioned earlier. He was one of the founding fathers of manual therapy in Canada. And it was really my good fortune to, in my very, very early years, I think I was only 5 years out from school, that I got to be mentored by him and practiced by him. And it was just a whole other world being with a clinician who thought, who clinically reasoned before the term was even coined, who thought about his thinking, and he got people better, and he knew he got people better, and he knew what he had done to get people better. And I said, when I grow up, I want to be like Cliff Fowler. And that was my early days. Yeah.
Well, it's interesting you mentioned Cliff, because I had spent some time with Cliff as well when I was there in Canada, and there was that trio, wasn't it? It was Cliff and Earl Petman, And
John Oldham,
yeah, John, I met John as well, but also another guy,
David
in
Lamb.
David Lamb in Calgary, just out of Calgary. Yeah.
Yeah.
And they really were, and all three of them were SAS or Green Berets. Is that, I think that's
They
right.
were in the army, and they were so I don't should think Earl was, but Cliff and Dave certainly were. They were both trained in the army in the UK, and then immigrated to Canada, very early with their wives, very early, and started in Ontario, and then migrated to. Cliff came all the way to BC via I think they were in Red Deer in Alberta. Anyway, they were in Alberta, and Dave stayed in Alberta, and Cliff came to the Wild West, and then John was from New Zealand, and he came up from New Zealand, and I think he met these guys in BC. So yeah, they were quite the days when things were starting, and I was so fortunate to be part of the whole evolution of the orthopedic system in Canada. Yeah,
it really was. And yeah. I mean, one of my memories of Cliff was saying, what are the 12 muscles that attach the clavicle? He just hit me with that when I first walked in the door, and I thought, wow,
wow, here we go.
This is this is the roller coaster ride. So, yeah. What was it about you working with Cliff that was particularly important for your development as a young physio?
Teaching me how to think about my thinking, number one. Always, like, he had deductive reasoning before he even knew that he had that. It was always the why, what, why are you doing this? Challenge and question sort of everything you do. And then also just the way that he, his hands were magic. And while he might not be able to explain the whys and what that got him to what he was doing things, he used listening touch before I even knew what it was. And when it would come to something that I was avoiding doing, so I mean, he was helping me become get my certification in orthopedics in Canada, which in Canada is called your FCAMP. The fellow of the Canadian Academy of Manipulative Therapy. And you had to pass these rigorous manipulation exams. And I was always afraid of manipulating the AA joint, the upper neck. It's just, we had the whole vertebral artery testing thing sort of scared the heck out of me. And it was like, oh God. So Cliff had put up a chart in his office, and every day I had to tick off on the chart what I had successfully manipulated that day. And it was very obvious a pattern was arriving. I mean, I had no problem with the thorax or the lumbar spine. SI joint was a bit of a tough go for me because you really had to use a bit more force. I don't manipulate them now. And the upper neck was just a blank slate. And so every time he would have somebody that he thought required C2-3, AA joint, OA manipulation, he'd just come and knock on my door. And he would just say to the patient, I need her for a minute, grab my hand and take me into the room and go, do the left OA. Do the right bits, do that. No clinical reasoning, no nothing, no stability checks, no nothing, just pure trust. Okay, Cliff, if you say so. And I one time, I'll never forget, he came and said, I want you to do an extension manipulation or inferior glide manipulation on this fellow's C2-3. And it was always the hardest ones. Like, now we know you don't have to be so direction specific all the time. But anyway, then we didn't. We thought you had to be. And I'm hitting this poor guy's neck and nothing's happening. And then he threw an x-ray up on his x-ray viewer and he says, what do you think of this? And I looked at it and I looked closer and I went, I think that joint's fused, Cliff. And he goes, yeah, you weren't listening with your hands, were you? You were just trying to impress me. Get out of here. Listen to your hands. So I'm sure you had the same experience with him. He'd set you up for some lesson somehow. And he obviously knew the fellow's neck could tolerate what I was doing, but it was just like so many times driving home, ripping my steering wheel off, going, oh, he got me again. He got me again, because you should never blind trust anybody, you should always be feeling and listening and going, why am I doing this? Oh, anyway, yeah. So the hand training, the manual training, the thinking training, and just like you had, how many muscles attached to the first rib? I don't know. Well, I'll go home and look it up. And there was no Google, right? No internet, no Google. It was like, how do I look this up? And you're thumbing through the pages of Gray's Anatomy and running to the library and going into the stacks of the library, trying to find articles and things. And yeah, it was a different day.
Yeah.
It was a different day. But he, yeah, he knew he had trained with James Syriacs. He knew Freddie Kaltenborn. He knew everybody at the time, and they had such high respect for him. And I think one of the things that Dave and John and Cliff decided, and Earl and I were probably the first mentees of these guys, and what they decided at the beginning was not to follow anyone, not to become we're going to become a Maitland Canada. We're going to become a Kaltenborn. This is going to be a Kaltenborn program. It became integrated right from the very beginning, that we're going to take all of it and we're going to integrate it for whom is this model or method appropriate. So integration has always been, Canada's thing. And so we never really had the battles or the wars over, a Mackenzie approach versus a Maitland approach. It was always a Canadian approach, which was all of it, and for whom. And that requires no recipes or protocols, but just an ability to think. And they were the ones that started it like that, and it remains that way to this day.
Yeah, and that's, I guess, unknowingly, that's what I noticed when I was there doing the EV program, was that I suddenly realized this is so eclectic. It's got a lot of Maitland in the assessment. It's got a lot of Kaltenborn in Syriacs, in the frictions and the soft tissues, and then some cellular Charmin stuff in the muscles. And it really was, a potpourri of all the best things around the world at the time in a manual therapy course, and that made it quite exciting.
Yeah, we had very little access to evidence that was really applicable to our practice. Like, there weren't very many physiotherapists doing PhDs at the time. There wasn't a PhD program for physiotherapy in Canada. And research was just starting in early 80s. And so we didn't have any of that to fall back on. Our evidence was almost 100% based in clinical expertise and clinical experience. And with the evolution and arrival of evidence, I think it's good, but it's also stopped some critical thinking. It's also stopped some creativity, and people don't feel that they have permission to do things for which there's no evidence. And yet most of the patients that I see, there's no evidence anywhere that duplicates their story. They're excluded from all studies because they're too complex. They have too many comorbidities. And, if you've ever been pregnant, if you've ever had surgery, I don't want you here, and it's like, okay, well, that eliminates 90% of my practice. So it's difficult. And I actually don't really recognize my patients anymore in the RCTs that are published. It's some generic person who has pain, right? And it's all seems to be led by pain, which is not the way we've been practicing for 40 years. Our practice has always been led by function. What can't you do that is causing nociception, neuropathic pain, or nociplasticity? What can't you do? And if we can restore function, then the nervous system hopefully will take care of itself, right? Unless there's a processing error. And at that time, we didn't even know anything about central sensitization or nociplasticity. So there's been a lot of really good stuff that obviously has evolved. But we also lost a lot of stuff with clinicians who really believe that if you're meant to be evidence-based, that means there has to be a piece of research out there that's going to tell me what to do for this person. And that's killing us. That's killing us.
Yeah, well, that's so true. And I remember sitting down listening and talking with Brian Mulligan about that. And he sort of said, look, my job as a clinician is to treat them and find out how to get them better. And then it's up to the researchers to prove why it's happening. But it certainly wasn't going to slow down his creativity in developing a program that was effective at the coalface, which is helping patients improve their function.
And there's nothing better for me than seeing young therapists who either come through the clinic or come on courses start to get creative and start to get curious, if you like, about their assessments and what they're doing, and to see the passion come back for the profession when they can actually see a path, or they can see a way forward for this individual. And if they can motivate them to make these changes, to see the rewards that come back, right? yeah, it's not, it never gets old helping the new clinicians organize all their knowledge into a framework or a way, and then for them to be able to recognize what's missing, and they can go trundle off and take all the multiple courses that are available and sort of fit them in their closet organizer once they have a structured way or an organized way of determining who's what's appropriate for whom. And I think that's what I now call the integrated systems model, or this model, which is a regional interdependent approach, looking at the relationship between impairments. So just because your knee is sore doesn't mean I'm going to treat your knee, especially if it's an insidious onset. We've got to look at foot control, hip control, pelvic control, all of the things that possibly could be overloading the knee. And very rarely are you treating insidious onset knee pain by treating the knee. Now, if you have an acute knee injury, of course, the knee is the place that you go. And we could be talking about back pain, neck pain, you name it, right? But it's about having a biomechanical framework where we're not judging people. We're not saying, ooh, your posture's bad, you shouldn't be doing that. We have an idea and looking at what one moves, and we think, maybe that's not such a good idea, and offer up a suggestion or a change. So if I gave your pelvis a bit of control, a bit of a hug, some force closure, and now you step forward on that leg, what does it feel like for you? And we let their nervous system be the judge, better, worse, no change. So if you are applying and people don't like this word, but I use it anyway, a correction, which is simply a change. If I change this, and it makes your neck get sore, or if you feel that you have to use more effort to move, then I'm not going in the right direction. But if I can align or control or change something, and you go, wow, that feels amazing, I know I'm on the right track, because that person's nervous system has less threat, less pain, less bracing with it. And so we initially judge, but then we always test. And I think this is where what we started with the 3-month manual therapy course that you were on, in terms of the whole biomechanics, sort of number of years ago now, to where we're at now, to a lovely model that allows us to test our hypotheses and not just have them and say, you shouldn't do that, you should change. You can go, this might be better for you if you sat in a different way, or stood in a different way, or had an orthotic or didn't have an orthotic. Right. So we're looking at, what do all these changes do to other places in the body? And it takes away a lot of the hard work, because it's the person themselves that determines whether it works for them or not. Mm-hmm. Yeah, hard to research this method, because there's so many balls in the air and so many pieces. But in reality, it's very simple.
Yeah, you're taking the complex and making it simple, but there's a lot of, I guess, background. It's like the tip of the iceberg, you're seeing the tip, but there's actually a lot behind that sort of concept. And I guess that can be a bit confronting to new grads, because you're asking the body, but you're also applying a lot of clinical reasoning behind that, like, why might I be doing that?
Yeah, I thought so too. And we didn't have new grads in the clinic for years. And then last year, there was a young gal who was treated in this regional interdependent manner when she was a teenager and had injuries playing soccer or football. And then she went into physio school because of her experience. And all the time through school, she kept saying to her physiotherapist, when do I get to learn the why behind the what? Why and when do I treat this knee, and not just what do I do with it? And Sean Campbell was her physio, and he said to her, oh, you're not going to learn that at school. You're going to have to go and train with Diane. You're going to have to go do the integrated systems model series after that. That's when it's come together. So when she graduated, she approached me, and Sean had said, I'd love you to meet this gal. And I go, I don't hire new grads, Sean. I mean, our caseload is so complex. Let her go get confused somewhere, and then we'll put it all together for her. But within an hour of meeting her, I thought, this gal knows exactly what she wants. She's known what she's wanted since she was 16. Let's see where we can go with it. And my senior team just looked at me like deer in headlights. We're doing what? How's this going to work? So she did the 6-month mentorship program, and also was mentored by 2 of us for 2 hours a week in the clinic. And she has done amazingly well. And because she had nothing to not unlearn, but she had no other models to integrate. She had no other she just knew how, this is how I would treat a back. This is how I would treat a hamstring, but not why. It was so simple for her to just take the whole approach and learn it. And everybody on the course was quite envious that she was beginning her career with a method like this. And now she's going off and doing her manual therapy courses, wants to get her dry needling, because she knows where it all fits into it, right? She knows where it all fits. So yeah, we can train new grads this way. You just have to be careful the caseload that you give them, right?
Yeah.
So you can't give them somebody that's really, really complicated, that's got multiple impairments and a phenotype of pain that's more nociplastic than nociceptive. Then that gets more difficult.
When you, after working with Cliff and receiving your mentorship and getting direction, like, you obviously then stepped out into your own private practice. Was that solo or in partnership with someone? Like this,
Yeah,
and this
no,
is
it was
after your
solo.
husband got his dental degree too, I guess.
So Cliff had it was an interesting arrangement. He had his practice almost like a duplex with Alan Morgan, who was another fairly senior clinician and instructor from Ontario who moved to BC. And they had their own businesses, but they shared a reception area, and then they had their own treatment area on either side. And Alan needed somebody to cover his practice for him because he had sudden difficulties with his heart. He had multiple sclerosis that had a flare up, and he just had a number of health issues that happened. And I was supposed to go and work with John Oldham. I had taken a job with John, but this is the whole network, and John and Cliff talked, and basically they decided that Diane was going to run Alan Morgan's practice for him, and while he was off. And I was coming from the workers' compensation board, where we had like an hour just to put a hot pack and interferential on someone and then sit and pick your nose. So I go into practice and we have 15-minute appointments, and I'm supposed to assess and treat someone in 15 minutes. And the first afternoon I had 3 hours and they saw 19 people. I'll never forget it. And at one point, I just didn't know what to do with this person. I went and knocked on Cliff's door, and he had his feet up on the desk and he's reading something. And I said, "Can you help me with this?" And he said, "Sure." And he did some quick little thing and said, "Do L5 and they'll be better." And the patient said to me, "What are you going to do to my L5?" And I went, "Hell if I know." And I ran out and I said, "Don't you ever do that to me again. This is not the way you teach. I need more than that. I need more than that." So I settled into a rhythm of working Alan's practice for him and being mentored by Cliff. That's how it started. And in the beginning, I would sit with my pile of charts at lunch, and he'd say, "Tell me the stories. Tell me who you saw this morning." And I hadn't a clue what I was doing with anybody, but slowly over the period of the year, the clinical reasoning started to come. And then Alan got better and he wanted to come back to his practice. So he told me he was meeting with me on the Friday. And I told Cliff, "Oh, he's going to let me go." And Cliff goes, "No way. He'd be nuts to let you go. He's going to hire you." I said, "I don't think so. He's going to let me go." And so on the Friday, that's exactly what he did. He said, "Thank you very much for the year. I'm coming back to work on Monday. See ya." Like, no notice, no nothing. And meanwhile, my husband's in dental school, and I don't want to go back to the hospitals. I don't want to do that. There's, 3 private practices in BC at the time: John Oldham, Jim McGregor, and Cliff. That's it. And they didn't have a spot for me. So Cliff knew my dad was in constructions in Kamloops. So he phoned my dad and said, "What are you doing for the next 6 weeks?" My dad said, "Yeah, not much." And he phoned George Akins, who's an orthopedic surgeon, and said, "Hey, George, is that little space still open next to you?" And George goes, "Yeah, why?" "We're going to build Diane a clinic." So he had my dad come down, and I had zero money to do this. And so my first clinic cost me $20,000, and that's what I owed the government in taxes. So I used the tax money to buy this clinic, and I was 27. And he said to me, "Do not go meet a doctor. Do not show your face. You look like you're 20 years old, not 27. We're going to send you some patients. Just do good work and your practice will grow." And that's exactly what happened. I just sat there and did what he taught me to do, and sent out a lot of progress notes, and nobody knew how old I was, how young I was. And here I was in business by myself. And yeah, that's how the practice started. And it went from 500 square feet to 6,500 square feet in North Delta. And then in 2000, I sold that one because I wanted to move out of that where I was and move to a different town within the Lower Mainland. But yeah, that's how I got into private practice. Yeah.
Wow.
The bank didn't loan me any money because they said that my chances of being successful in private practice were the same as if I was to open a shoe repair shop on the top of a mountain. Yeah. So that's how much they wanted to give young married women in 1981. Yeah. Yeah.
Thank goodness for mentors. I mean, that would have to be the most extensive mentoring I've ever come across.
Oh, it was just, yeah, phenomenal. He was a mentor all my life. Yeah.
Yeah. Next big step, I guess, and this is I'm thinking about the young physios that are listening to this podcast, was that you wrote your first book, The Pelvic Girdle, in 1989, which says a lot for your interest in pelvis or all things to do with pelvis. For younger physios that are listening, do you have any advice on writing and publishing a book?
So the story around this one involves Cliff as well, because the invitation for that book came from Gregory Grieve in the UK. So it was right around the time when Nick Bogduck and Lance Toomey had submitted their proposal for writing the book, The Clinical Anatomy of the Lumbar Spine. And at the time, the pelvis was becoming very trendy in physiotherapy circles. And so Churchill Livingston, as it was known at the time, which became Elsevier, Churchill Livingston really wanted Nick and Lance to include the pelvis in their book. And Bogduck refused because he said there's no evidence that the sacroiliac joint moves, and this is quackery. There's no way we're going to put anything about the SI joint in this book. And so the board at Churchill Livingston asked Gregory Grieve if he knew anybody who was skilled enough to write a book on the pelvis. And he said, yeah, my good friend Cliff Fowler in Canada. And they said, well, can you reach out to him to write a book? Well, if they'd known Cliff well enough, like his writing skills and his verbal skills weren't his best, and he would admit that. So when Greg Grieve called Cliff about this book and what he wanted to write it, he says, no, I'm not going to write it, but Diane will. So that's how that started in 1989. And that was 81. And it took 8 years to get that book to press because I want it to be as evidence-based as it could. But that meant going to the University of British Columbia every weekend, going into the stacks, walking downstairs with stacks and stacks of journals after going through Index Medicus and trying to find articles. And then you'd have a handful of nickels stand in line at a photocopy machine, throw them in the machine page by page by page to get your articles. So 4 hours of work might get you 3 or 4 articles. Now that may sound laborious, but it's almost as overwhelming now to just do a search and send to your librarian, can you do a search for me on whatever topic, and then get inundated with pages and pages of references, right? So I wanted to go back to the 1900s. I wanted to see whatever was written on sacroiliac joint since 1900. And integrate it and go from there. So it was a really good experience to just, because I was writing really from my experience for the year in terms of working and training with Cliff, who was really, really interested in the sacroiliac joint and its relationship to low back pain, groin pain, hip pain. And the model we were using at the time was very osteopathic. So Ed Stiles had come to Canada and had introduced the osteopathic approach to the pelvis, which was more of Fred Mitchell and his father's kind of way muscle energy kinds of things, forward and backward torsions, anteriorly rotated anomas, a very positional approach, right? And so that first book was really just documenting what we were doing at that time. Then in 1992, I was working at the clinic, and this little green book, the 1989 book, had landed on the desk of Andre Vleming. And Andre Vleming, as hopefully most of you know, has been the chairman of the World Congress on Low Back and Pelvic Pain since its inception in 1992. And he had just finished his PhD, and he was really passionate about the pelvis. His supervisors had said to them, don't do your PhD on the sacroiliac joint of the pelvis. Everything is about the disc. let's figure out the low back pain and the disc. And he said, no. Like, look at these fascial connections that are going from the slings, that are going from latissimus dorsi through the glutes and crossing through the back. I want to study the pelvis. And so when my book landed on his desk, he was interested in it, wanted to hear more about it. And so he called the clinic, and he has a very strong Dutch accent, right? So he's from Belgium. His first language is Dutch. And my receptionist could barely understand him. He says, there's a guy on the phone, and I think his name is Vlaming or Vlaming. Do you know him? And I went, take a message. Take a message. Oh my gosh. I can't believe I did that. Anyway, I called him back a little bit later, and he invited me to come to the very first Congress, World Congress on Low Back and Pelvic Pain in La Jolla in San Diego in 1992. And I would have 15 minutes to discuss the relationship between the low back, the pelvis, and the hip. in 15 minutes. So I got there, and there was only men presenting, only men. And I had this lovely navy blue suit that I bought to present in. And everybody else was presenting in a navy blue suit. So I thought, I can't wear this. So I went shopping, and I found this jacket. I won't forget it. It was like Joseph's coat of many colors. It had all these crazy different colors on it. And I don't know what made me do that. But anyway, I wore that and talked about the relationship of the low back, pelvis, and hip for 15 minutes. And what transpired from that was I got to travel with Andre from 1992 to probably 2010. I mean, we still are really good friends, and I've been all over the place with Andre, teaching courses and spending many hours talking about manual therapy. And he'd be saying, it's fiddling, give it up. It's all about training slings. It's all about exercise and emotions. It's the emotions that really get people going. And I'm going, we can do things with our hands. Anyway, I could talk for hours about this lovely guy. And it was through his exposure internationally that I was introduced to Paul Hodges in 1995. And I was sitting next to Paul at a conference on the Gold Coast, and we were both presenting. And he asked me if I knew anything about tranny. And I went, tranny? Didn't want to be stupid. I don't think so. Transversus abdominis. And I went, that skinny little flank steak in our body? He had not had one article published at that time. And after hearing sort of his work on transversus and the motor control and listening to Andre and the rest of it, I knew that we had to move beyond the joint, that manual therapy had to go far beyond biomechanics. We had to start looking at myofascial slings. We had to start looking at motor control. And yes, of course, emotions were important with it. So it led to the whole integrated model of function that Andre and I developed in 1998, looking at form closure, force closure, motor control. And each edition of the Pelvic Girdle book has told the story of who has mentored me over my career. So the second edition in 1999 was a lot of the integrated model of function and work with, and then the third edition layered on all the contributions from the UQ group with Julie Hides and Paul Hodges, and looking at motor control and its relationship to pelvic girdle function. And then the fourth edition in 2010 is where the integrated systems model sort of came, where we started looking at drivers and looking at remote system impairments and its relationship with pelvic control. And that's when I was working very closely with Linda Joy Lee. And so there's been, the books have been a journey of mentorship. So for the young, for the young therapists out there, I wouldn't say that my experience and career has been that much different than many people I know. But what I've done along the way is document it. And whether the books that I've written have been self-published, such as the first edition of the thorax book, second one now is with Handspring Publishing, the two abdominal wall and DRA guides that are both self-published, or whether you are commissioned by a publisher. What writing things down and putting things out there do is creates our history. It creates a document that actually really shows the journey of physiotherapy over time. over time. And so
Yeah, well,
it's important to write those things down and not to be afraid that we may not have the evidence for everything that we're doing, right?
well, when you sort of detail that, the pelvic girdle does almost parallel the development of our profession, starting off on a manual osteopathic and then moving into a bit of a myofascial and then moving into a biopsychosocial model. It's really
Totally.
starting to integrate all those components, and they're all important in every patient as well.
Yeah, and I hate it when people hold me back to 1999 and say, "Oh, we know what she does. She looks at the PSI as going up and then does this because it won't go down." And it's like, "Oh, no, 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 come on." I have learned a few things since 1999.
I think, and that's put that out there because I know, talking to Peter O'Sullivan, he, the one thing that he always says he laments is titling his PhD the instability of the lumbar spine in regards to his stuff. He said, now we'd never say that, but the reality is, at that time, at that point of our development and understanding, that's what it was. But it doesn't
Yeah.
mean that it's not true to its time. It's like history, isn't it? You've got to look at a piece of, something that happened in the context of what was happening around it, and that's the important side of it as well.
Oh, so true, so true. And it was how we were using the word instability. The word stability and instability itself became like the six blind men and the elephant. It meant different things to different people, and therefore the word itself became useless to us, because unless you defined what you meant by using the word, communication became difficult. And I hope that doesn't happen with the word control now. Like, we're kind of substituted stability for control, knowing that control, we have to control our joints in some way, and it doesn't seem to get as much abuse as the word stability. But yeah, for sure. Yeah.
As part of your journey, you've traveled and taught, as you said, a lot around the world. How has this experience for you sort of influenced your understanding in clinical practice?
Oh, it's just really made me realize the more years I practice and the more I learn, the less I know. You meet so many. I just have been so fortunate to meet so many incredible people and clinicians through my travels, and to be, when you have an open mindset and you watch people work and you watch sort of how they work and the results that they get, which can be totally different from what you would have done. It makes you very humble and respectful of the human form and the human body, and that there isn't just one way to help someone get better, and that every clinician needs to develop what works best for them. How are they best able to influence and to change behavior in the person that they're working with? So not every method is going to be appropriate for everyone. And I've seen so many different clinicians work in different models and get great results. So it just makes you humble. It makes you humble and makes you realize that there's still lots to learn. And that's the beauty of this profession. If you're bored in it, if you don't like what you're doing, that's your fault. Go change it. Go find something different, because you can be creative. You can develop and create products if you want. You can travel, and if you find that you're burning out of seeing too many patients, then there are so many other things that you can do that will really open up the world to you, if you just care to take the risk and try. So I'm not a risk taker. I'm not sure that I chose to do that. It was one of those things where, like, Andre called me, "Do you want to come to California to do this?" And I went, "Okay." And I didn't say no to it, right? Let's see what this is like. And the book itself, like, how much money do you make when someone else publishes your book? Peanuts. You don't. But you make more than money. You create opportunities. People reach out to you and go, "Hey, I'm really interested in what you wrote here. Can we chat? Can we talk?" And I have such a worldwide network of friends now that I could travel forever and not teach, and just go visit people and play and explore. And there's just been so many gifts from being able to have the honor of dropping into their curriculums or dropping into their continuing education and taking them on a journey. But my company is called Learn With Diane, not Learn From. And I really treasure that word with, because I learn as much from teaching as I give. So it's a two-way street. So the highest form of learning is to teach. You really understand your topic well, or don't, you know where the weaknesses are. And when you care to listen to the others who are listening to you, it can just be a gold mine of ideas and of take you in all sorts of different directions. So very inspiring to meet people all over the world who have the same mission as I do, and that's just to help people live a better quality of life, right?
Yeah. If you could change a decision or experience that you have had, what would it be and why?
If I could change, I think the only thing that I would have done, I was reflecting on this question, is that I would have bought a building in my 40s. My husband really wanted us to stop leasing and to buy a building and put the dental practice in one half of the building and the physiotherapy clinic in the other. But it was going to cost $2 million. And when I was 42, I didn't, that was a big number. It'd be like 6 or 8 million now. And we didn't do it. That is of all of the things that I've done, I thought about this question when you sent it to me. What do I have any regrets of anything that I've done, or what wouldn't have done? Yeah, I probably wouldn't have continued to lease the space in my building. Yeah, that's it. It has nothing to do. I had nothing to do with clinical practice. Nothing to do with. Yeah, with that, I would have bought a building.
And the question, I mean, I won't say the answer, but the question is, why would you have wished you bought it? I think I know why, but just so you clarify it.
Why did I reach that decision?
No. Why do you wish you had bought it?
Well, there would have been more equity in it, in the sense that yeah, probably just more financial than anything else, and being able to design it and not be limited by the design of the building already built, to be able to create and have your dream space. I would have had more money per month to be able to invest in equipment I wanted, without, that thousands of dollars going out every month to pay the lease. But you would have had a mortgage, of course, but the mortgage you would basically have been paying yourself. Yeah, I don't know. That's probably the main reason.
That's good, because that's a blend of both, because people, physios is a profession, but then you have to become a business. So there's just as important to understand, yes, you're going to have a mortgage, but you will have the flexibility, as long as you can make the payments, you can create and design your own space. And you have an equity which is rising with time, hopefully, as appreciation occurs. So, you're moving with the tide, as so to speak, financially, if you can maintain those commitments. But I like the idea that it's yours. You can do with it as you want, creativity-wise. And I think that also reflects our profession. We're going from a manual therapy to an exercise model to a Pilates studio to functional rehabilitation. So we need to have those almost bigger spaces to enable us to run lag classes or osteoporosis classes or all that sort of stuff. It's a moving model, and having your own space means you can do that sort of stuff.
It is. Yeah. And I think, since 1981, I've been a clinic owner, and exactly as you say, it gives you the flexibility and a little bit more control and return on your investment over time.
Yeah. What's your hardest lesson that you've learned, Di, being a physio?
That you can't fix everybody, that to step back and recognize when you either don't have the skills or the person is in the wrong place, and you keep them coming for too long, or you keep them coming to the point where you feel ineffective or whatever. And it took me a long time to feel less than, to feel, oh, if Cliff saw this person, he'd get them better. If Earl saw this person, he'd get them better. To feel comfortable knowing that I've done my best, and whether it is that I just don't have the skills for this person or not, when is the right time to really refer them elsewhere, or to tell them, I just don't know. I don't have any more tools in my toolbox for you for this. And that's hard. That's hard to say, sorry, I couldn't make a difference, and to be okay with that at the end of the day, and not ruminate over it and feel less than, or, we all start off with the imposter syndrome, we sort of kind of feel not good enough. And then you get to a point where you start to feel capable in some areas, and then you branch out into something else and the imposter syndrome comes back. But there's always going to be a patient that comes through your door where you don't figure it out. You can't make a change. Things don't change. And you have to come to that point where you kind of go, this is it, in their best interest. It's in their best interest not to see me anymore. Not because, often because I just don't know what else to do or what else to offer them from all the tools that you have. So that's probably, and to know that I will never be a fixer, that I can only be a coach. And if somebody is not yet ready to take the journey that I think they need to take in order to feel better, if they're not ready to work on function, and they are still looking for, where's the pain coming from? I need another MRI. You got to find out where my pain's coming from. And if they can't let that go, and they can't start getting stronger and start working on whether it's motor control or whether it's mobility, whatever it is they need to do, to realize that sometimes it's time to say goodbye for a while, and yet you've still planted the seeds in their brain, and it's not uncommon for them to come back in a year or two and they say, okay, I get it, I'm ready, right? And it's also hard, I think, the lessons are when the psychosocial barriers are actually the driver, when they are the barriers to the recovery, or their beliefs and their social relationships or their work relationships that are just so toxic that you're just creating this upregulated sympathetic nervous system. They're always in a state of threat, and it doesn't have anything to do with their biomechanics. It has everything to do with the relationships that they have themselves in. And I don't feel confident enough to say, you should get out of this relationship. But I can hold up a mirror and I can say, have you thought about how you feel when this person walks in the door, or how when you're working with this, and when you get into these situations, how does your body respond to that? Bessel van der Kolk's your body keeps the score kind of thing. And when they don't get it and they go, no, it's my SI joint and it's out. You just need to put it in, and aren't we beyond that? Yeah, so those are probably the hardest ones to know. When is it time to stop? When do you stop? And also the other hard lesson is not paying attention to when those spikes go up in the back of your neck when you first meet someone and you really go, I don't like you. And it doesn't happen very often. It doesn't happen very often that you meet someone and you're just going, I don't even want to be in the room with you, let alone help you. You're not going to. If you can't establish rapport and you can't at least like this person to take them somewhere, it's not going to work. And then as a clinic owner, I have to decide, is there somebody with a different personality than me that's better suited to work with this person in the clinic, that I can be justified in saying, I'm going to put you on this person's caseload. I think you'll do better. You'll do better than them with me. And I usually say I'm not available enough for what you need. That's kind of how I do it. But really it's that I don't want to, and I think someone else is better. But I think if somebody is not appropriate for the clinic at all, then I don't let them stay. And those are hard. That's hard. And that's been a lesson, because when I've sort of panned them off onto another therapist because I don't want to see him, I hear about it and have to deal with the problems anyway as the clinic owner, right? I have to deal with either their complaints or the therapist's complaints or admin's complaints. Yeah, doesn't happen very often. Those are the hard things. And also hard to let someone go when you make a bad hire. So when you hire someone that isn't a fit for your team, or isn't a fit for the model that you guys practice in the clinic, and the patients are falling off, like they see them once or twice and then they go, they're not coming back because they're not getting the same kind of care that they get from other people. And it doesn't mean that what this person is doing is not good. It's just not what's expected from either the patient or it's not the expectation of the clinic. And then having that hard conversation that is about, yeah, I screwed up, made a bad hire. It's not about you. There's going to be a place where you fit, but it's not here. It's time to say goodbye. And not honoring those feelings. So that's the tough stuff about being the boss, right?
We've gone from being a clinician to the hire slow, fire fast business philosophy of being a clinic owner or employer.
It's the hats we wear, right? I mean, and that's
totally.
multiple hats. Yeah,
totally.
Yeah. Mm-hmm.
Getting to something nice and simple. For $200 or less, what's your best app or tool or investment that you've made in yourself to assist in your clinical development?
A great anatomy text.
Yeah, I mean, you
An
probably say
anatomy
digital
text.
now.
It all comes back to anatomy, right? Yeah. And for me, it's not an app. It's I love my real anatomy books. McMinn, and I can't remember the name of the other authors. They're over there. So Gray's Anatomy probably would be the one that might go to. And there's Rohe or something. Yeah, I love the real anatomy dissection books where you're actually looking at things. For me, anatomy book.
I know you did I think it's the Chan Gun, because I think you mentioned intramuscular stimulation of your course, but the thing I found with the dry needling I found really interesting is diving into the radiology textbooks, the serial sections where you can sort of look at the depth anatomy. That's something that we don't tend to get as much in the topographical stuff.
I'd love that. Ooh, yeah, that sounds great. Well, the apps do that too, right? And they're layers.
Right.
It's someone's drawing of it, and I don't trust it. I don't trust that it's real. I need to see the real.
Well, and even going back one step further than that, I mean, when you start to go back to the cadavers and you look in the anatomy labs, you realize anatomy is not literally cut and dried. It's very variable, and there's lots of variations that we've got to realize the person in front of us might be that 12% variation that doesn't have this or has an extra one of that. And it's good to remind ourselves that drawings are just a drawing. It's an interpretation. It's not always reality too. So
are prepared cadavers. So in 2010, correct, when the fascial conference was in Amsterdam, and Jaap van der Wal just did a brilliant presentation showing that there's no such thing as a ligament, that the connective tissue in the body is just all thickenings and changings and everything else. And the only time we see a ligament is when some anatomist tends to cut the cadaver in a way that makes us see this thing more, Iliotibial tract is just part of the fascial lata of the entire thigh. He really blew my mind with that presentation, thinking, in Guillaume Bertho's work, right? Everything connected with loose connective tissue, that the skin isn't separate from the bone, and there's fibrils and connections all the way down. Anatomy. Yeah.
So I think, like you sort of said, we've gone from the mechanical to the myomechanical to the biopsychosocial. I think the last, well, who knows it's going to be lasting, but we've got to throw the fascia in there as well now, because literally it's linking it all together. Absolutely. Okay, so what would you say is your most out on the limb decision that you've made in regards to your career, and what was the outcome of that decision?
So I would have to say, in thinking about this, was when I made the decision to resign as chief examiner of the Canadian Orthopedic Manipulative Therapy Association. So I was examining fairly experienced therapists for 20 years. And it is in Canada, as far as physiotherapy goes, a pretty prestigious position to have, right? But what I really felt that was happening, and still do, with the orthopedic division, is that it was standing in the way of orthopedic manual therapy becoming a master's degree program in universities. So it was all sort of outside of and not affiliated with the university. And I really felt that we were standing in the way. And I think that if many of us had stopped, that it might have encouraged the movement of the whole program into university-based. So now we have two university programs now, one in Western Ontario and one at UBC here, but they took a long time to come. Letting go of that group was feeling like I was amputating a hand, because it was letting go of all the senior manual therapists in Canada, Carol Kennedy and Elaine Mathieu and Laurie McLaughlin, and all these people are working so hard to further the education of young therapists that were coming up. And I left for a couple of reasons, because I really felt that the program should be in a university, and that as long as the program was successful and kept going, it wouldn't go there. But I wasn't so egotistical enough to think that just me leaving would make that happen. It was also because the program was staying too much in the joint. By 1999, I had learned more from Andre and Paul Hodges and the UQ group about the role of motor control. Lorimer Mosley's work was just starting then in terms of like looking at pain neuroscience. And none of it was getting incorporated into our program. Now, I'm sure it is now. Yeah, I'm not sure. I'm not sure exactly what's in it, to be honest with you. But at the time, we were still, if the joint won't go up, you got to find a technique to make it glide superiorly. If it won't go down, you got to glide it inferiorly. And that wasn't my clinical experience. My clinical experience was that joint manipulation techniques have more of a neurophysiological effect and can change things than they do biomechanical. Now, that doesn't mean if you have a stiff joint that has a restricted superior glide, that you can manipulate it any way you want. In fact, I don't manipulate stiff joints, I mobilize them. But a joint that's held compressed by overactivation of multifidus, rotatories, thinking in the thorax, that's going to respond to a needle, dry needle it. It's going to respond to a specific distraction manipulation. It's going to respond to, reset. And we'll make it change. And I have a left-right dyslexia. So sometimes when I turn people prone, I forget which side I'm on, what left and right is, or the other way. And there was many times that I'd figured out, okay, I need to make this joint glide superiorly. And I would make it glide superiorly and realize, oh, shoot, I'm standing on the wrong side of the patient. I did the wrong joint, and sit them up. But the range of motion was restored. And you kind of go, how do I reconcile this biomechanical model thing in terms of what I need to do? And so it was hard for me to examine and mark somebody as being right or wrong, because they had done something that matched my clinical experience, but was marked wrong for this exam because it was supposed to be a different glide. So I was too much the devil's advocate, and it was just time to leave and create something of my own that was a little more integrated. But from 99 to now, it's been a lonely journey. I've missed a lot of those people for a while, not being part of the collective of great minds, and that's probably an out of a limb decision, the outcome of which is that I've lost touch with the bees and the who's who in the orthopedic division in Canada, but I gained connection and community with like-minded individuals, researchers and clinicians alike worldwide. So my network of people now are, in Japan and Finland and Denmark and Australia, United States. They're not in Ontario and Quebec, where most of the OrthoDiv stuff in BC here is being led. I've retained contact with a couple of people in BC, but it was too difficult to watch after a while. And even now, when Kate's going and doing the level courses here to get her manual therapy stuff, and I said to her, "You're going all the way. You're going to go all the way and get your FCAM, and we're going to mentor you through it. And when it comes to the clinical reasoning stuff, let's chat." Because a lot of it is not what she has learned in the last few years from a regional interdependent approach. And so, yeah, anyway, that was probably the most out on the limb decision that I made, was to quit a program or to quit the division that I actually created the curriculum for. Back in '83, I actually set up the OSCE exams from used to be Cliff, Dave, and John sitting there grabbing a question out of their head, no prep, no nothing. And so I created 13 or 14 different exams that were randomized. So, and John had to ask the question that was in front of him, right? And it couldn't be just what he thought the answer was. We had an agreement as to what would be accepted as the answer. So we started to standardize the exam, and I had developed all of that in the early '80s and brought some structure to the whole orthopedic div, and then walked away.
What three things stand out for you professionally so far in your career?
They're not things, they're people. So I couldn't find three things that sort of stood out, but
Three
the
highlights. They can be
three
they can
highlights.
be human or not human.
Yeah. So the three highlights for me, number one would be the power of mentorship. So Cliff, Andre, and Paul, they just the journey that they took me on, that whole thing, the mentorship. They challenged me, my beliefs, my experiences, and they've absolutely been responsible for a lot of my growth as a clinician and also as a human being. These guys. The other thing is, it has probably been the privilege and the honor of helping someone get better. That someone trusts you enough to allow you into their life, to touch their body, they trust you enough to prescribe for them what it is that they should do. And at the end of it, if there is a success story, just at the end of it, just that feeling of the privilege we have to work with other human beings to get better. So again, it's not one single thing. It's just that experience again and again that just will never let me give up clinical practice. So there's many, many clinic owners that don't touch patients anymore. They only do admin in Canada. They just do admin and they manage. There's a lot of educators in Canada who don't treat patients anymore. And I don't know how you can do that, because if you're not getting fueled by the practice itself, I don't know how you can be the best educator that you can, because the stories come from the clinic. The examples come from the clinic. If I hadn't been working through COVID, I wouldn't have realized how important it was to get into trauma-informed care, to dive into Porges polyvagal theory and understand what the stress and trauma of the fear of getting sick with COVID and infecting our grandparents or our parents, and the kids not, being safe going to school, and what that was doing to our moms. I wouldn't have felt it. I wouldn't have seen it. And there was times in 2020 when we opened back up again, when our care was so psychological. People just wanted to come in and talk to another human being that wasn't their family, and be held, be touched without being gloved. We didn't glove, we hand sanitized, but it was incredible being part of working through that pandemic and being in the trenches with the team and knowing what they were going through. Yeah. So those are probably two things. The last thing that stands out for me is opportunity, that opportunities in this profession are profound. And, but they don't always come to you, that you have to seek them out. But you can, as I mentioned earlier, you can do so many things in this profession, and just go get it. So how much we can do and diversify that we can do with this. And people say, oh, you're still so passionate about what you do. How come you're not going to retire? I mean, I'm 69 this summer. Why aren't you going to retire? And I went, what would I do? This isn't work. This is life. This is life. Yeah.
Yeah. If you could step back some way through time and have a chat to your younger self, are there any bits of advice that you'd like to share, knowing what you now know?
Yeah. When you're old, you want to be young. When you're young, you want to be older and wiser. And it seems like we always want to be where we're not. And I think what I'd say to my younger self is, and younger people, is you are right where you are meant to be. And so stay in the discomfort, work hard, and the rewards, both personal and professional, will come. So, and just keep learning. Never think you know enough, because you never do. I know a therapist I worked with at the workers' comp. She didn't like me much. I don't know why, but she didn't. I got the energy feel from her. She didn't like me much. And she'd say to me once, I've forgotten more than you'll ever know, young lady. And I often think of Pat now, and I sort of think, gosh, I feel exactly the same. I've forgotten more than people will ever know, but that's probably not true. But it is uncomfortable in the early stages. It is difficult. And it's supposed to be. It's not supposed to be easy. But just sit with it. And as long as you have one experience a day where you kind of go, that's a great story, or this was fun, then you're on your way. You're on your way. Cliff used to say, surround yourself with your successes. And if you can do that and you have your successes around you, then it won't feel like work. You won't feel like work.
Yeah. I like the idea of being comfortable in discomfort. And it sort of seemed, I was just talking with another lady a little while ago, Linda Kong, who's a Singaporean Australian who's done lots of things in the area of lymphedema, which is a tough gig at the best of times. And she has that same philosophy that, you've got to step out of your comfort zone and be discomforted, because that's where the growth is. There's no growth in comfort. And I really like that, really resonated with the things that, I've done, and you've just, expressed that same thing in a different way. So I think that, today's society, we may be getting a little bit too comfortable, and in that way we limit our growth. So it's good to hear from different people that have gone on and done a lot of things, that part of the ability that they achieve what they have achieved is by being comfortable and stepping outside and being discomfortable in that process.
Yeah, well said, Doug. Yeah, I would agree. I would agree with that. Yeah.
Looking forward, where would you like to see our profession of physiotherapy heading in the next few years?
I would like to see less specialization and more of an integrated approach to return, where instead of, I hear so many therapists that say, oh, I'm an expert in the knee, I'm an expert in the back, or I'm an expert in the neck. But who's the expert in the person? Right? There's so much to know about the whole body, and it's just impossible to know it all. But we have to have a framework where we're looking at everything in relationship. I don't think we have to choose between hands-on or hands-off. I think the better question is when to use our hands and when to use our voice. And most often we need to use both, right? There's a place for manual therapy. There's a place for exercise. There's a place for education. And it's knowing when to use what. I know I couldn't work without the training that I have had in my hands. And we were speaking before we started about the sommelier, the person who is trained to understand the region, the age, I'm not a big wine drinker, but all of the things that a sommelier can do. And apparently they can identify 400 different taste sensations in their mouth. And Jean-Pierre Barral says that we can develop the hand to be as sensitive. And I don't know if that's true, but we can certainly develop the hand for being much better if we use it. And I think the research from music is clear on this. If you look at the brain maps of a violinist versus the brain maps of a piano player. So in a piano player, both sides of the brain, both the left and right hands, the brain maps are very large because they use both hands. But the violinist who uses the left hand in a very fine-tuned independent finger way versus the bow has a very different brain map for the left hand and the right hand. So it develops with use. And I think it's exactly the same with manual therapy. And so often the people who don't believe in some of the things we find. So if we take a thoracic ring, for example, Punjabi has shown us in 1976 that when the thoracic ring rotates, it translates contralaterally 1 millimeter. And people have said, you can't feel 1 millimeter of translation. We do the same thing in the SI joint. It moves between 4 to 6 degrees. How do you feel reliably? 4 to 6 degrees of movement. And the people who challenge that are the people who can't find the finding because they haven't trained their hands. And you can't interpret a finding you can't find. So the loudest voices are the ones who aren't very good because they haven't put the time in to train their hands. That's one of the reasons for it. The other reasons for the intertester reliability, the poor intertester reliability we have, is that the human body is dynamic in the way that it moves. And every time we move or do something, so take the mobility test for the sacroiliac joint, which has 12, more than this now, but at 2010, when I presented this at IFOMPT in Montreal, at that time, there were 12 intertester reliability studies that showed we couldn't agree on whether the PSIS goes down relative to S2 on mobility testing. When Barb Hungerford was analyzing her research on this stork test in 2004, we were sitting on a beach in White Rock together looking at her data. And she had 484 data points for every time the person stood on one leg and lifted the other one. And what was interesting is that the degrees of motion for anterior posterior rotation, abduction, internal external rotation of the innominate were different every time the person lifted the leg. Now we know that diverse motor control strategies are healthy. The more we do things differently, the better it is. So now bring all that evidence to an intertester reliability study. How do we know that the person who's lifting their leg is doing the same thing every time? So unless we have a machine that can measure at the same time as the tester is testing it, you have no idea if the same thing happened between tests and between days. And in fact, Joe Abbott, who is a biomechanist in the UK, has just finished an 8-year PhD looking at this part of this intertester reliability. And she actually built some gloves that had motion sensors in the hands. Okay, she built these and used the Vicon system. And the test that she used was just transverse plane rotation of the pelvis. So is one side of the pelvis more forward than the other? And at the moment that she said now, a marker was put on the Vicon system. Sorry, I'm not explaining this well. And the data was compared at both of those points, right? So Joe would have said the pelvis is rotated to the left, and the Vicon system would calculate whatever it did and said the pelvis is rotated to the whatever it was. She was right 99.9% of the time, and her margin of error was 1.6 degrees. So if the pelvis was only rotated 1.6 degrees, she couldn't pick it up with her hands. We can be that good with our hands. And we have this kind of reliability. But looking at intertester reliability and intra-tester reliability will never show reliability if we are looking at it with the human form, because they do different things every time they move. And Doug, the most consistent thing about a motor control deficit is its inconsistency. People do different things every time they move. They use different strategies. Sometimes it moves and sometimes it doesn't. And so how do we reconcile that? Well, we could go on for 12 hours talking about reliability, but there are a lot of problems with the evidence around it. And that body of evidence is one of the main reasons manual therapy is getting thrown out, because the first thing they look for in any test is reliability. And Joe's point is that if the hand's going to be used as a measuring tool, it has to show validity before reliability. You wouldn't use a thermometer to measure distance. So in a lot of the studies, is the hand the most useful thing to measure what it is trying to measure? Has got to be the first question before we go for reliability. So we're going to see some work with some publications come out from Joe Abbott over the next 3-4 years, and it's called HODA-A, Hands-on Data Acquisition and Analysis. How do we acquire data using our hands, and how do we analyze it? And how do we get agreement? And why don't we get agreement is what her thesis and her PhD has been all about. And it's one of the things that keeps me going, because I think the pendulum's going to come back and we are going to see people scrambling to learn how to use their hands again. Fingers crossed.
Well, I want to pick out two things that I thought particularly, I mean, there's a lot interesting. One is the development of the skill through the practice, and we take the violin as a great example, particularly when you compare it to the piano player. And secondly, we use the hands for two things. One we use to assess, and one we use to treat. Yeah. And I think that's an important point too. The focus has been on the hands as a treatment tool. And I think people are forgetting that the hands actually are primarily, you've got to have them as an assessment tool, which is what Joe's stuff is starting to show us now. But I think it's important to point out that you can't develop your hands-on skills without the utilization and conscious practice of using them.
It's true.
The brain map is real estate, and if you don't occupy it with the usage of, say, testing and calibrating with finger touch, then something else takes over it. It's competitive real estate in there.
Yeah, absolutely. Yeah, absolutely.
All right. And then the big question, what is Diane Lee going to do over the next few years? You said you're 69, you're an honest lady. You like to, that's,
Next
I'm
summer. I'm
impressed.
60.
I would have said only 57, but if you got to say 69.
Yeah, no, I'm 68, 69 next summer. Yeah. Well, and so by that, most would think that I'm in the autumn of my career, but I don't really feel that I am. And I hope to really continue to learn and then share what I learn. I was in Australia at the end of November taking a course with some colleagues, and one of the things that we learned was what happens to the cranium for newborns delivered by a forceps. And I've been seeing a number of newborns born with lots of pain when they lay on their back, lots of fussiness. They cry a lot. And this one child I'm thinking of in particular, a lot of difficulty turning his head to the left. The occiput's in 4 pieces in the newborn. And I'm learning that with using our hands, we can change that. And in one session, I had this child being able to lay on his tummy, turning his head to the left, nursing from his mom's right breast. His whole sphenoid and frontal area started to expand out. Didn't see the changes in the occiput that I would like, but I'm very curious and interested with the newborn cranium at the moment. And so I will always have a small clinical practice, and people are always asking me, when are you retiring? I live in Squamish now, which is halfway from Vancouver to Whistler. It is a beautiful sea to sky highway, but it's a difficult highway to drive in the dark or the rain. It's a bit scary. It's when they race all these cars on. And so I've always said, as long as I can drive that highway, I will be in the practice. And the only thing that's going to stop me would be a stroke or dementia. I'm just going to keep going. And what I've realized in the last year is that I love new grads. I love new grads. They are so passionate, exciting, and they're just little sponges and ready to go. And I love working with them. So I'll continue doing that as well. So I am bringing the ISM series course to Sydney, Australia this year. So for any of you out there listening and you want to come join me in a 6-month mentorship, Kathy and I are coming to Sydney. So it's on the website. Love to meet some of you there. So I'll still have I don't know what I'm going to do with the clinic, Doug. I think over the next, I've got a succession plan kind of happening within the team, within the clinic itself, so that I want it to stay intact. I want it to stay exactly as it is. I sold one in 2000 and I sold it to a big corporation. Made a lot of money, but I hated what I left behind, in the sense that people were in this corporate thing now. And Bill Lyons, who's from Tasmania, took it over for me, and he just did an amazing job sort of keeping everybody integrated and ran a great team until he died this summer. And I really want to leave the legacy of that place and people in place where there's always mentorship, where people feel safe to come and be vulnerable and learn and know that there's no such thing as a stupid question, and there's no competition, and people are collaborating and sharing. So yeah, I'm not done yet.
Diane, thank you so much for staying up late and joining us on Physio+10 and sharing an absolute rainbow of ideas and thoughts and experiences and journeys. And I'm sure there's going to be a lot of people looking forward to catching up with you in Sydney if they can get to there, and if not, look forward to seeing you when you next arrive on the Australian shore. So thank you very much for joining us on Physio+10.
Thanks for having me.
Thanks so much for listening to this episode of Physio+10, in which I trust you gained some valuable insights. It'd be awesome if you could leave your 2 cents worth as a review or rating of this podcast, and I look forward to sharing the story of another trailblazing physiotherapist with you in 2 weeks' time. Stay safe. Bye for now.